Good afternoon, everyone. I am so excited to be with you today and to talk about what we are learning about relationships and their impact from a treatment perspective. Before we dive in, I just want to take a moment to thank the ADAPT team for letting me be a part of this work, both in the development of the model that I'll be talking about today, but also just as a co-author in the health promoting relationships paradigm. It's been a true honor and a gift, and it's one that has changed my personal life as well as my professional life. So over the next time that we have together today, I plan to take you on a journey that highlights a model we have put together and have been using across two communities for several years. And I'll share a little bit about what that model looks like. We'll talk about what we know from prior research about how relational aspects between treatment providers and clients impact the treatment process and outcomes. And then I want to spend the rest of the time just highlighting what we have learned from the staff implementing this model, and most importantly, the youth directly in terms of what they believe are the key ingredients to treatment success, what they've experienced within these programs, and how that has correlated with behavioral health outcomes. So the model that we'll be talking about is called the Catalyst model. And really it's, what exactly is it? And so just before we talk about the what, I just want us to touch on the why this model and why now. So the two communities where Catalyst is being implemented are in a drug trafficking corridor that has been hit hard by the opioid epidemic, and not unlike many communities across the US. But one of these communities in particular, for example, was consistently among the top counties within its state for rates of fatal opioid overdoses. And so prior to the program, providers described seeing youth that were being raised by caregivers other than their parents due to family substance use. And these youth were struggling with their own trauma and other risk factors. And the hard part is the need for the substance use treatment and mental health services for youth went unmet. There were clear gaps within the system of care to not only identify those with risk, but also to provide treatment to them. And, as is often the case in less urban communities, lack of transportation too was an issue in increasing access. And so all of these factors created a perfect storm. And that is where the Washington-Baltimore HIDA and the ADAPT team came in. They helped to provide funding and guidance, collaborating with key partners in both communities to build the Catalyst model. So Catalyst stands for Community-Based Assessment and Treatment for Adolescents and Families to launch interventions for substances and trauma. So I know that's a mouthful, which is why we always call it the Catalyst program. And essentially, the goal of the Catalyst model is to provide a continuum of evidence-based care from prevention through to recovery for youth at risk of or struggling with substance use and co-occurring issues like trauma, depression, anxiety. And in addition, the support is designed to be geared not solely for the adolescent, but also for their families as well. So the two communities implementing Catalyst are in Martinsburg, West Virginia, and Winchester, Virginia. So more specifically, the two primary outpatient adolescent treatment centers include the Day Report Center in Martinsburg, as well as the Valley Health Hospital's outpatient behavioral health program in Winchester. So since the beginning conversations about identifying what was needed, both of these communities have had key partners at the table, including the local juvenile justice systems, which included judges as well as members of probation services and even some lawyers, to prevention groups, to schools and other entities. And, for example, in Martinsburg, the Day Report Center works closely with not only juvenile probation, but also with the juvenile drug court in the area. And so in both of these communities, the treatment centers have developed close relationships with the schools as well. And that has led to being able to provide treatment on site to youth at the schools, which again, when transportation is an issue, has really helped to increase access. So here's a view of the catalyst model, and you can see kind of the foundation and how it kind of rises up one through five. And in addition to the ongoing collaboration across community partners, which is at the foundation at the bottom, community partners and youth serving organizations, the Catalyst model really strives to implement routine, universal, and secondary screening for substance use and mental health concerns. And so that's along number 2 that you see in the model. And so, for example, in Winchester, when youth enter the emergency department, they are routinely screened for substance use, depression, and anxiety. And youth can also be universally screened within their schools. And so the way that screening kind of translates into intervention is that for youth that have low levels of risk, where maybe there's an emerging concern, but it's not risen to a clinical level, those youth can be provided with early intervention by the person conducting the screening or the person reviewing it. For example, within schools, oftentimes brief interventions are conducted by the guidance counselors or school-based social workers or clinicians. And so youth scoring with clinical risk are referred to the Catalyst treatment program. And in addition, youth can arrive at the Catalyst program through other ways of being identified. And so, for example, we've had youth referred due to getting caught using substances at school or home, having physical altercations that somehow they become involved, with probation, truancy, and other types of clear risk factors, including mental health symptoms. I was talking to a young woman who participated in Catalyst this last week, and she was struggling with suicidality and depression, and that's how she ended up getting referred to the Catalyst program. So youth referred for treatment are offered a range of services, from individual and family treatment to urine drug screening to taking part in peer recovery groups. And so for today, the data that I'm going to share with you are from, like I said, the staff serving in these treatment programs and also the youth who have participated in these programs. And it's important to note, and you can see the names listed of the different programs that are utilized, but across this continuum of care, the programs really strive to utilize evidence-based programs. So across both of these treatment programs, in order to provide the array of services that you see on the left side of the screen, actually, I think, yep, on the left side, they often employed a team of folks. So this can include a case manager who often did a fair amount and continues to do a fair amount of care coordination to ensure that youth could access services, to facilitate ongoing communication with other important adults and programs in the youth's lives, and other important tasks. It also included licensed counselors to be able to provide individual and family-based treatment for the youth. And then each program employs a certified peer recovery support specialist. And at different points, for example, the Day Report Center was facilitating 3 peer recovery groups for youth per week, in addition to offering individual recovery coaching. And the evidence-based programs that are utilized by the teams at the Day Report Center in Valley Health included the use of psychometrically validated tools for assessment. And so what I mean by that is it included measures like the CRAFT for adolescent substance use, or the patient health questionnaire for depression, or the child PTSD symptom scale. And these tools can be scored with guidance to understand the severity of symptoms a given youth may be experiencing, which is really important when looking at matching different types of treatments for what they're presenting with. The programs also utilize contingency management, and so youth and families were offered nominal incentives for their engagement in the program. And while a number of clinicians were trained in and could utilize practices like EMDR, as you see listed there, as a treatment to address trauma, our program also provided the clinicians in training on trauma-focused CBT, or cognitive behavior therapy, training on a program referred to as MET-CBT, which pairs motivational interviewing with cognitive behavior therapy to address substance use. And staff were also trained in family systems model of brief strategic family therapy. And Family therapy is encouraged, especially for youth where there is ongoing conflict in the home. So while all these programs are great and they have a lot of evidence behind them, they would all fail without youth feeling a connection to or relationship with the staff. And so I know you've heard some of the previous speakers sharing information about the critical value of relationships and connection. That's what the whole day is about, right? And I want to take a minute and do two exercises. Both of them are Slidos, so please get your phones out. Let me make sure. Okay, so for the first one, in one or two words, describe what it is like when you've shared something with someone else and they've either not gotten it, they're not interested, maybe they share something about themselves back immediately, or some similar response. Hmm. Invalidated, disappointing. And I should tell you, with word clouds, the words that are popping up as larger means that there's a larger number of responses behind them. So you can see feeling unheard, frustrated, disappointed, disconnected, anxious, ignored, uh, upset. Yeah, you can see there's just a lot of, people feel bad. They can feel shamed or judged. They can feel less important or in general less than. And so I appreciate everybody kind of sharing because it sounds like you get it. You really get being on the receiving end of wanting to be heard and having that not happen. So this is great. And in the interest of time, I am going to keep moving forward. I love the one, by the way, that says, "Ugh, so disappointed." I totally appreciate that sentiment. So now I want to do it again. And in one or two words, now think about what it is like when you're vulnerable, you've shared something that maybe is really difficult with someone, and you feel seen and heard, you feel like they get it. Valued, relieved, relief, feeling connected, love, comforted, feeling special, feeling blessed, respected, empowering. Uh-huh. Absolutely. Accepted, affirming, warmth. These are all great. Exactly. And so if you consider, just take for a second and consider, we just saw a screen where pretty much the exact opposite of the words that are coming up here presented themselves. And so just considering the dramatic differences that you may have felt between these two types of responses we just spoke of. And, while it may seem far-fetched to think that a treatment provider might respond in a less than optimal way, it happens. It happens. And I know that we've kind of through the day, the different speakers have been just sharing stories about how much presence and how much deliberate focus it can take to be intentional about how we show up and how we work with youth. And that applies to therapists in the treatment context as well. And, I have the privilege of listening to therapists getting certified in one of these particular models. And I can tell you that unfortunately it happens for very real and understandable reasons, but they really are missed opportunities for sure. So thank you for taking part in that. I appreciate it. So as we talk about relationships, I think it's really important to acknowledge how the context of treatment is a bit different from a lot of other contexts through which youth move. So within treatment, there's an expectation, a necessary element, and it's that of confidentiality. It is one of the fundamental dimensions of the context of treatment that youth know, with the exception of areas where imminent harm is present, that what is shared is kept between the youth and therapist. And while I have youth that don't trust this element right away, I have had other youth that come into treatment letting out all of what they have been holding in, almost like a balloon releasing its air. And in fact, for one of our Catalyst participants, she had experienced significant trauma and was estranged from her family. And she had unbelievable trust, just the way she talked about it for the Catalyst team. She actually used the word family when she described them. And when I asked her, I said, given what she had shared with me about, what she had experienced, that it can be hard to walk into a situation like treatment and trust. And so what made her decide to trust them? And she talked about how within 10 minutes of her meeting her therapist, she found she started to share what she was going through. And that early on in the relationship, while there definitely was a feeling she got about the therapist, she also was conveying the context too was critical. Knowing that she had a confidential space to talk about what she was going through and how that made a difference for her. And along with that is that by entering the context of treatment, there's also this expectation or understanding that uncomfortable and sensitive topics are going to come up and be discussed. And so for me, as a licensed psychologist myself, it's how we communicate about and hold number one, confidentiality, that helps to support youth to be okay with number two, which is this idea that we're going to have these uncomfortable conversations together. And so I just want to be clear that confidentiality is necessary, but it's not sufficient to engage youth in a meaningful way. And, I will say, given this context, though, treatment providers really have a unique opportunity to provide human connection and empathy within the treatment relationship for the goal of promoting our clients' health and well-being. So you heard Laura mention earlier the facilitators of connection, and I know a couple of the panelists also spoke about them in the last session, and these are really critical. I mean, we know from the literature that more clients leave treatment early after a single session than at any other point in treatment. And the expectations of treatment that I was describing a second ago highlights the very real vulnerability that clients feel upon entering treatment. So from the beginning, how you show up as a provider tells your client whether they can trust you, whether you're going to be able to understand them, and whether they feel like you're going to be helpful to them. Now, I do have one caveat. So often clients for substance use and youth clients may be mandated to attend treatment. And so one may ask, how does this apply when youth don't have a choice? And I will tell you again, in my experience, youth who are mandated and don't feel that the therapist, quote, passes their assessment, they will do a range of things. They'll either not come back and take the alternative. I've worked with providers where I've seen youth leave services and end up taking the charge if it was a legal issue. They may not come back and instead advocate strongly to go to a different provider in the community if one's available to them. They may come back, but in a way that tells the therapist who's paying attention that they're just going through the motions. And in fact, some of the youth that we interviewed indicated that they did this for the first several sessions until they felt that they could trust the staff. I had one youth actually tell me that it was about the fifth session, they felt things shift for them. And they said they started to want to lean into the program. I also had another youth say that once they saw the clinician following through on what they said they would do and what they said they wouldn't do, then they knew they could trust them. And that's when they started to allow themselves to be more forthcoming. So within the health promoting relationships paradigm, we reviewed literature that emphasizes how the quality, structure, and function of our relationships with others contributes to individual and population health, community safety, resilience, and prosperity. Laura went over that briefly this morning, and it's from Dr. Vivek Murthy, the former Surgeon General. He highlights this research in his 2023 publication of Our Epidemic of Loneliness and Isolation. And the therapeutic alliance is really about the quality and strength of the relationship between the client and therapist. And you can see how it's measured, that not only by looking at collaboration, but more specifically the bond between therapist and client. And research has found that a strong therapeutic alliance predicts better engagement, retention, and outcomes in youth substance use treatment and treatment more broadly. And 75% of studies have found there's a significant relationship between the therapeutic alliance and outcome for people. And so to me, the takeaway is that youth will likely not act on skills without collaboration, trust, and the foundational relationship. So in other words, the relationship is just as important as the treatment method. And once we build collaboration and connection with our youth clients in treatment, they will be more ready, willing, and able to benefit from the evidence-based treatment model or skills that could benefit them. So I want to highlight one more piece of data about relationships before we move into talking about our actual data from the program. And this, you can see in this figure on the left-hand side, it talks about contextual model factors. And these include often what we think of as elements that come from the facilitators of connection and can be found in micro skills for trusted adults. So you see the stars below the ones that overlap, including things like supporting youth autonomy or agency by fostering true collaboration, conveying empathy, forming an alliance, affirming authenticity or genuineness, and having clear expectations. So the thickness of the bar reflects the number of studies that are available looking at that factor in relation to therapeutic outcomes. And for example, if you look at therapeutic alliance, it says alliance on there, it's the third one in. The bar represents data from over 200 studies involving over 14,000 patients. And they found that the relationship between therapeutic alliance and outcome had a 0.57 effect, which may not mean a lot, but what I will tell you is that is a medium to medium-sized effect. And in implementation literature or treatment literature, if you're seeing a medium or a large effect in what you're looking at and how it's related to outcomes, that's huge. That's really significant and really important. So all that to say, the science in treatment maps onto the science for developing health promoting relationships with youth more across different contexts. You know, Carl Rogers was one of the founders of client-centered therapy. He said it best when he said, in my early professional years, I was asking the question, how can I treat or cure or change this person, right? Now, I would phrase the question in this way. How can I provide a relationship which this person may use for his own personal growth? So we know from the treatment literature, it's not all about the evidence-based intervention you're using. And we know that, yeah, evidence-based interventions, they're important, they're necessary, but they're not sufficient. And so how have we carried this forward and seen this within our programs? So I'm going to shift to talking about our data now. So to get the staff perspective on the overall implementation of the Catalyst model, we interviewed 12 staff across the 2 different organizations. And for the purposes of our time here today, I'm going to focus on the themes we explored that relate to staff's philosophy on working with youth, as well as the characteristics and strengths they strive to use. So it was clear from the staff that key themes after interviewing them included building relationships and connections with youth. This was essential. And to be able to do that, staff believed that you needed to create a safe space, a welcoming environment, and attitude. And even when the youth didn't want to be there at first, you needed to meet the youth where they were at consistently, time and time again, being patient and flexible. And staff also shared that to support youth, they felt they needed to believe, model, and convey consistently to youth that they can overcome challenges that they're facing and lead productive lives. And again, they emphasize that it's not only their belief system, but also many of the staff were in recovery or had a loved one in recovery or had faced similar challenges. So they felt that they could relate to what the youth were going through and that they could serve as role models for youth. And actually, many youth in our interviews with youth spoke to how important this was, seeing people who had been where they were and had gotten through it. So the other piece is really continuing to reassure youth that they could get to a place where they felt healthier and where life felt more positive and full. Staff also expressed a belief in the evidence-based models they chose as being models that allowed responsivity to the individual needs of the youth they serve. So part of our process when we were developing the model was to work with the two different organizations and their clinicians around what were the range of evidence-based models available and which ones seemed like a good fit for their community, their program, their staff. So their enthusiasm about the models was in part due to the fact that they wanted to be creative and they wanted to be able to meet youth where they were at while using models they knew worked. They also continued to reassure youth that they can overcome their situation, that they would not be in that situation forever. And there was one youth I interviewed where she had talked about how this was key for her. She had been in a long-term residential facility in a controlled environment, and then when she left it, she had come to the Catalyst program, and she said a key coping mechanism for her was to know that her situation was not permanent and that she's getting through it and she's going to continue to get through it. So I wanted to just highlight several of the statements Catalyst staff shared about how they view their role and how they find meaning in it. As one staff said, "I love working with teens. I feel like it is a gift to be able to do this. Not everybody gets to do a job that they are investing in the future, and that is what I feel like I do. I am changing the generational dysfunction that was created when this opioid epidemic hit our area. It kind of ransacked the lives of so many people. And 3-4 years ago, when I started working with juveniles, I realized they were kind of a lost population." In other words, that this staff feels passionate about their role in supporting youth. You can see that they have a strong concept of mattering for themselves in their role as a therapist. The second quote I want to share highlights how staff go about striving to provide an environment that really meets youth where they're at, accounts for how that environment might need to be modified to best meet the needs or foster comfort, and increases an opportunity for connection. So as staff shared, having lots of fidget toys and games can really help youth engage, and that they try to provide a truly trauma-informed, safe environment, as that makes all the difference because a lot of these kids just don't feel heard anywhere else. And lastly, here's a snippet of how staff feel that they need to show up for youth. Youth are very sensitive to those kinds of personalities, and they can pick up real fast if they feel someone is judging them or whatnot. Just someone who is very open-minded and caring and really striving to put the patient's needs first, no matter what. So that one, I feel, for me, it highlights the idea of non-judgment and acceptance, as well as honoring the youth by putting them in the driver's seat. So to expand on that last quote, here are the words pulled from our interviews with staff that emphasize the characteristics and strengths they believe they need to embody when working with youth to build connection with them and increase their ability to make positive changes in their lives. And hopefully you're seeing that a lot of these map on to the 16 facilitators of connection that are important for health promoting relationships with youth. So I want to shift gears and talk about what the Catalyst youth have to say, because they have a lot to say, which has been really great, really wonderful. So, as we talked about earlier, when youth enter treatment, these are the questions that they're asking, either knowingly or unknowingly, consciously or unconsciously. And inherently, we all, if any of us have been in treatment, and I can tell you that at one point I'm in mental health recovery myself, that we all do this to some degree when entering the context of treatment, which is, what am I doing here? Am I safe? Can I trust this person or place? Will I be listened to and heard? Will they understand me? Will my feelings and values be respected? Can they really help me here? And do I have a say in what happens in this interaction? So one of the things we do is at the 6-month follow-up time point, so from intake to 6 months in treatment, and even if they're not in treatment, we still try to get these interviews as well. We interview the youth, and part of what's unique about these interviews is that myself and my colleague, Kathleen Scully, are responsible for conducting these interviews. And we make sure the youth understand that we are not employed by the treatment organizations providing services, and that we do not share their individual responses back to their teams. And we did this so that youth would feel as free as possible to be open and forthcoming. And we've interviewed over 160, sorry, over 160 interviews have been done with youth, and we're adding to that number every week. And initially, the interviews really focused on youth's achievement of their goals and what they felt helped them to make progress on those goals. But in the last year, we've really shifted our interviews starting in January to focus on the youth's perspective of staff characteristics and ways the staff have interacted with them that they feel has been helpful for them. So here, I just want to highlight this graphic here breaks down the themes that emerged for how youth described their experiences in the program. And you can kind of follow the arc from left to right, but youth reported choosing goals around improving their mental health, changing unhealthy habits like substance use, and developing healthy coping behaviors. And I always frame that question as, I know that coming here may not have been your initial choice, but I'm curious to hear what your goals were when you entered services. They consistently describe treatment activities, which is that second list. As again, you're moving through the arc. They consistently describe treatment activities that included establishing goals, building a trusting relationship with their therapist was key, and then learning coping skills and improving their emotional regulation. And with the youth recovery groups, youth felt it was a supportive community with people who had similar experiences, and that this was really cool, that it helped them to overcome their fear of talking to others, and that they felt they learned how to communicate better through the group process. And even with the drug screening, youth described how they felt they were being held accountable, and that as a result, they also gained back trust with their guardians and caregivers, and that was important to them. And we're going to talk about the next two in more detail in a second. So I want to skip to the family involved outcomes. And that's the one that's over on the far left, second from the bottom. And youth described treatment as helping to improve their communication with their caregivers, and that their caregivers, they had gained a sense of respect as well as positivity within their family. And we did interview with some of the parents that went through the family therapy, and the parents themselves said that they were better able to respond to their youth in a healthier way as well. So when we talk about the skills youth acquired, these are the themes that youth described in terms of the skills that they felt they were gaining. They talked about being able to do better goal setting for themselves, being able to make and maintain a schedule, being able to even just believing in themselves and becoming self-affirming, learning how to set boundaries, particularly with their friends or peers, and then using different types of coping mechanisms. So they talked a lot about breathing or distraction or grounding exercises, and grounding exercises are particularly important for people that have experienced trauma. And you can see the rest of the list, but these were the different skills that youth themselves were saying they felt like they were getting. And we ask an open-ended question. We ask when they experienced a shift in the behavior, the question is really about, how did you do that? And these are the skills that are emerging of what they're describing. So when youth were asked what characteristics staff show that help them to be successful, these are the themes that emerge. So again, if you take a moment to think about the facilitators of connection and the micro skills for trusted adults, there's a good degree of overlap with what youth are saying help them. So I wanted to just pull a few quotes so you could get a sense of the youth's experience in their own words. The first one, being able to listen to me talk about things is very important. And the respect they show me makes me feel like I mean something and I deserve the respect they are giving. And overall, just the way they make me feel as if they do care for me. So here youth's really talking about feeling that they mattered. For the next one, I've never really liked school because I've been bullied. I have had trouble making friends, but she helped me to talk. She helped me talk to people. I feel like she has taught me how to see the good in things. So this idea of learning to adopt a hopeful or positive outlook. And this last one, your future depends on you and your mindset. Whether you are willing to change for yourself and do better for yourself. They helped me realize that I needed to do better for myself. And so just through the process, motivating the desire for them to do better for themselves and not necessarily versus others. So you can see, I mean, this is one of the joys of my work week is when I get to interview these youth because there are multiple quotes like this. And it rocks me every single time, every single time. So we have the feel goods. We see that relationships are helping youth to feel respected, to feel that they matter. And through these relationships, youth are identifying too that they're learning skills and making healthier choices for themselves. Hold on, I want to make sure I'm coming through. Okay, and hopefully everybody can see me. The reason I do that is that I just got a notice my connection was unstable. So hopefully y'all can hear me, but I'm sure somebody will let me know if you can't. So, youth are identifying that they're learning skills, making healthier choices for themselves. And, we wanted to see if that translates to impacting youth's actual substance use and their mental health symptoms and behaviors. And so, as a routine part of the Catalyst program, this is something we built in from the beginning. We re-administer the clinical tools that are used in the intake assessment to be able to look for a change in symptoms and behaviors over time. We also look at the urine drug screen results as well. So we ask youth and guardians to sign a consent, and part of that consent gives permission for our team at our center to continue to try to contact them to complete the follow-ups, even if they've discontinued services for any reason. And youth get a $20 gift card for their participation in that portion of the follow-up, and they get a $10 gift card for the interviews I talked about a minute ago. So, there are a couple elements I just want to highlight here. So of these data are the first 3 years of program implementation. We are now in our 4th year. And so of the 681 youth that were referred, about half engaged in services, as you can see. And many of you may know this, you do know this, I know, is that this is a difficult population to engage into treatment. There's no question. But I also think it's important to note that we had higher rates of a lack of engagement in the first year compared to now. And part of that was further developing our relationships with our referral partners. And in addition, both programs over the last couple of years were able to create MOUs with schools and start providing services in school settings, which really helped to increase access significantly. And so we are always continuing to try to boost engagement and retention. And at the time of these analyses, you can see that we had 144 youth that were currently active or who had successfully completed the program. Slightly more had been discharged before completion. And just due to the timing of that, the interviews occur at 6 months post-intake, not all youth in this sample were eligible to complete their 6-month follow-up yet, simply because they just hadn't reached that time window. And so across all 3 groups, approximately half of those where time had reached where they were eligible for the 6-month follow-up, approximately half completed interviews, or 52%. And that's the data I'm going to present to you here. And so I just want to say from the get-go, we do realize that there are limitations in our data. This is a community-based evaluation. And so, we did do a comparison of intake scores among those who completed the 6-month follow-up versus those who did not. And we did not see any significant differences on any of the measures at intake, indicating that at intake, the severity of symptoms and behaviors were the same for those 2 groups, which helps us to rule out the possibility that, those who aren't completing the 6-month follow-up maybe, had a different severity of problems at intake. So on the right, On the right, I apologize. It looks like the slide did not format correctly when it got translated over. So I apologize for that. On the right, you can see the sample characteristics of youth attending Catalyst. So the sample's evenly split across gender with an average age at 15 years. And then as you can see, Catalyst serves a relatively ethnically and racially diverse population of youth. And I want to take a second to highlight the graph at the left. So this looks at the average length of stay in treatment services across the three groups I just showed you. So those who successfully complete treatment, those who were still active at the end of year 3 when we pulled data for analyses, and those who were discharged from services before successfully completing treatment. So they left early. And the orange line that you see, so the National Institute on Drug Abuse recommends in their principles for effective treatment that individuals attend a minimum of 90 days in outpatient treatment to be able to achieve good outcomes. As you can see here, the mean across all groups for the length of stay in treatment was 160 days, with even those who discontinued services early remaining in treatment for 2 months beyond the minimum recommended amount of time. So clearly, clearly the Catalyst team is successful at being able, for those youth that enter treatment, being able to retain them for a period of time, which is important when we start to talk about outcomes. So the chart on the left shows the frequency of substance use at intake as reported by youth. And so the dark blue bars are when youth reported using the given substance monthly, whereas monthly or less, whereas the light blue bars reflect when youth reported using substances weekly, but often daily. And so if you look at the two bars together for each substance, that tells you the total percentage of youth at intake that were reporting using a substance. So for example, nicotine, you see that there were 31% that were using monthly or less, and there were 49% that were using weekly or daily, which totals 80% of youth reported using nicotine at the time of intake. And so you can kind of see what the frequency is of substance use at intake across the population. And then if you look at the chart on the right, you're going to see that over time, youth significantly decreased their use of substances. So from intake to 6 months later, use of nicotine decreased from 80 to 46%. Alcohol decreased from 56 to 18%, and marijuana decreased from 87 to 41%. And these were statistically significant changes, and we also saw changes, significant decreases on the CRAFT, which is that screening tool I mentioned earlier, and it measures the impacts related to substance use. And then lastly, the urine drug screen results further supported these self-report decreases over time. So on average, youth completed 17 tests during treatment, some completing more, a few completing less, but that was the average. And 155 youth participated in testing, with over 2/3 testing negative consistently at their last screen, before and then up to their last screen. So we've seen significant decreases in mental health symptoms as well. So nearly half of youth score positive for some clinical level of anxiety and also for depression risk. And the chart on the left shows 2 lines. The darker blue one represents anxiety symptoms as measured by the GAD-7, and the lighter blue represents depression as measured by the PHQ-9. And a score of 10 or higher on these measures indicates the person is at moderate to severe or clinical levels of risk. And so as you can see by the orange bar there, that's where the score of 10 is. And then the green bar is where people dip below to indicate no or minimal risk. And so you can see between intake to 6 months, the average scores for youth with risk at intake dropped to below the no to minimal risk threshold. We also looked at trauma symptoms, and those were assessed using the Child PTSD Symptom Scale. And the trauma symptom questions are only asked to those who endorse experiencing at least one traumatic event, and nearly 2/3 of youth entering services reported experiencing some form of trauma. And types of trauma reported included physical and sexual abuse or assault, witnessing domestic violence, and witnessing or experiencing the loss of a loved one, at times due to overdose. So these youth had really been through some very significant experiences. So the average score of trauma symptoms decreased significantly across all youth who had reported experiencing trauma. And the average score fell into the mild risk level 6 months post-intake. So again, we're really seeing these positive changes in their mental health and well-being. So in summary, because I know we're at time to kind of wrap up, but in summary, the Catalyst teams have worked incredibly hard to build programs that strive to foster youth relationships with the youth that they serve, and utilizing the foundation of these relationships to help youth develop coping and other skills to be successful in their lives. And we are seeing the results both in how they're describing feeling about themselves, their outlook on their future, and in the behavioral choices they are making around risk behaviors. So the QR code is the guide. We have an implementation guide. It's on ADAPT's website as a resource, and you have the QR code there. And so if you're curious and you want to learn more about the model and what we did and how it's implemented in the different components, you certainly can. And I know we have some time for questions, so I just want to thank you for your time today.
Thank you, Dr. Kamen. We do have time for some questions, and we have had some come in. And I just want to take a minute and share with everyone what it has been like working with you as an evaluator. Because the Center for Behavioral Health Integration has, we put out bids, we follow this whole process for recruiting evaluators for various projects that we have going on here at Washington Baltimore HIDA. So I am switching hats here from Director of ADAPT to Deputy Director of Treatment and Prevention, because I oversee for our region treatment as well. And we went through this process, and immediately it was apparent in your bid, just kind of the spirit that you're bringing to this as well. And that came through in the approach and in your presentation. But I say this because many of you out there also engage with evaluators for the projects. And if you don't, we encourage you to. Always evaluate. That's one of our main messages at ADAPT is whatever you do, just evaluate it to make sure you're achieving the outcomes that you set out to achieve. And so, Jody, you are a gem to work with. And I just want to publicly thank you for the last many years. We've done several projects together, and this was a very important one in Washington, Baltimore, HIDA. And it's been a true honor to have you on this with us. We've had really rich questions come in. The first is, this was implemented in not necessarily rural counties. One of them, Berkeley County, considered more on the rural side. Winchester, a slight flavor of both, rural and urban. But how can urban cities adopt or benefit from this model?
That is an excellent question. And in fact, I'm doing some work with a couple of organizations in the New York City area around adolescent treatment. And I will tell you, in my experience, one of the pieces that I feel like is harder and not quite as present is the community collaboration. I feel like because there are significantly more players in the room, that it's harder to get people in the room to kind of agree on a shared vision. I know earlier presentations talked about creating a culture and creating a collaboration among these organizations that serve youth. And I feel like that has been harder. I think the parts that I was talking about in terms of treatment providers having similar philosophies and beliefs, I feel like we are seeing that, and they really are coming from a place of wanting to build that foundation of connection first. Yeah, so I feel like that first part has been what's been more challenging.
Thank you. Something that's also resonating with me about this question is it was so interesting to us. And as I heard you kind of share some of the qualitative feedback over the years with me, because Jody would call and say, guess what? Guess what? I just heard from another youth in a qualitative interview that spoke to the relationship piece. And highlighting that as a fundamental part of the intervention of all these evidence-based strategies that were being implemented for treatment, but the relationship piece really standing out. And so to me, that also seems like a really natural way and takeaway from your presentation, regardless of the setting, right? Or whether it's rural, urban, or whether it's outpatient, inpatient, whatever it is, corrections, that the relationship can be seen throughout as a very important piece to getting to the outcomes that you want to see. And this model really showcases that with its data. Do you want to respond to that at all?
I completely agree. I guess one of the things I had a follow-up thought because I realized I may not have fully answered the question, but I think the piece I just want to touch on real quickly is to answer like how do you do this? I will say grants or some type of donation funding helps, obviously. But I also think looking at where you can be able to access the training for these different programs. And then I think the message that's been started throughout here is this idea of how do you change the culture within a treatment organization by focusing on one piece at a time, right? So when you think about the relationship, the health promoting relationships, it's this idea of how do you work with your treatment team to shift if you feel like you really want to focus more on those connections. How do you shift and where do you start in terms of what feels most relevant within the HPR to the context of your program?
Okay. We've got a couple more and we've got 3 minutes left. I'm going to answer one real quick. Does it require police or court referral to implement? It does not require that. Here's the deal. We are HIDA, so our primary mission is disrupting, dismantling drug trafficking. We need a drug nexus, right, for our funds to be spent in a meaningful way for our funding source and towards that mission. So we required that one of the gateways for entry into the Catalyst model be the juvenile justice system. That was a requirement from Washington, Baltimore, HIDA. And it's amazing that the majority are coming from the juvenile justice system and benefiting from that, but it is not a requirement. So I want to just answer that quickly. All right, real quick. Someone is asking if you can explain at a beginner's level, and these are their words, and I'm appreciating that because we've talked about a lot of things today. We're covering a bunch of different subjects and concepts, but very simply, what's a good starting point for any community that might want to adopt this program, might want to look at it and examine it as a real possibility for their communities?
To me, it's getting the organizations or programs that work with youth in getting the leadership of those programs or the change folks, the people that can help kind of make some of those decisions in a room together to think about what would the value added of having this program and what would it look like and how would they need to work together to be able to bring it to life? Because I feel like that's where you have to start. You have to start with the community or the partners that you want to work with behind it. Because like I was saying, the referrals are coming from different youth serving organizations, but also services that were being provided in some of those settings. And so, it really does take a village of these programs to work together in that way. So I'd say get in a room, sit down and talk about what shared vision you have for trying to address substance use and mental health among your youth.
I do. Patty's giving me the sign. I'm probably going to take liberty and just maybe go 2 or 3 minutes into the break. One thing that is so important is that I want all of you to know we submitted this model to be funded underneath a SAMHSA grant originally. The center that the HIDA funding runs through is also its own center at the University of Baltimore, Center for Public Safety Innovation. And we worked to try to get this model funded by SAMHSA, and they funded a different type of treatment programming for that particular application. And Washington Baltimore HIDA decided to allow them to apply for our treatment funding here in the Washington Baltimore HIDA region. And that's how it got funded, because we didn't give up. And I want, to your point, Jody, these communities, Berkeley County and Winchester, they came to us at Washington Baltimore HIDA and said, we need something. We are struggling here. The overdose rate within Berkeley County and Winchester, extremely high compared to other counties as well. So they were actively looking for and hungry for evidence-based strategies specifically for youth as well. So just a little context there. There's a very important question here that, Jody, you were the perfect person to answer. Because of your psychology background and all of your behavioral health experience in schools, someone is asking, there's a recent change requiring parent consent for in-school substance use treatment that does not allow 100% confidentiality for the student. Do you have any recommendations on navigating this relative to building trust and engaging students in treatment when that's a real factor?
That's a great question. Okay, so I'm gonna have two quick answers. One, I would look at, so in our communities in Vermont, so I'm based in Vermont, and in our communities, what we have had happen is the treatment providers come in to provide services. So they are co-located with the school, but they are actually, the person is a client of the treatment provider, which creates more protections for confidentiality for the youth. So I just would say, if there's any way to look at how organizationally the infrastructure is to be able to provide treatment. The other thing too is if we have school-based clinicians, if they're co-located, there's more flexibility around that. In the absence of that, the piece I would say is you have to be super clear in one, understanding what that really means. Two, understanding what does that mean you're going to communicate with both the youth right away, as well as the parents right away about what you will and will not share. I have conversations with parents where I say, I can give you a general idea. I can give you a general idea of if we're making progress, but I'm not going to tell you the details of their use, who they're using with when, what situations, because they need to feel like they can come in and talk about those things. And that's a very real conversation that I've had with parents before, sometimes to their frustration, but you got to hold that line. So I think it's understanding what does that exactly mean within that school setting. And then from there, how does that translate to what you're clearly going to tell the youth and clearly going to tell the parents about what you will and will not share?
All right. We're going to end with this one because it's just too important not to address. How might we adapt this for Indigenous communities or other types of populations or communities that are really appreciating this, but not seeing the perfect fit, right? And wanting to maybe take pieces of this or explore what it would look like for the populations that they serve.
You know, so we in Vermont, we have our Native American community is the Abenaki community, and they adopted this model of screening with intervention for substance use, but they adopted it with a spiritual component of these 4 different spiritual elements that were specific to their community. And so I would just say, I feel like, and the process for that was sitting down and talking with the members of that community. In what ways would this be helpful to you? And if it's going to be helpful to you, how does it need to be adjusted? And then again, as you adjust it and you implement it to fit that community, you got to measure it. You got to look at how's it working? Because that'll tell you what you need to tweak if it's something new that you're adjusting to meet the needs of the community.
Thank you, Jody. Adopt team, would you mind putting my email in the chat box for any, because I'm technically the prevention representative for Washington, Baltimore, HIDA, and this is something that we are funding. If you have any additional questions about this model or would like to explore what it might look like to maybe have a conversation with the community about this, we're happy to share in whatever ways make sense. We can bring Jody in for that conversation, but go ahead and email me with those additional questions. The final thing is we've now had several questions about youth, the peer recovery specialist being a youth. And just for clarity's sake, the youth peer recovery specialist is an adult peer recovery specialist
Sorry, Beth.
working with youth. Yeah, so we could totally see how that could get a little mixed up. All right, Jody, as always, thank you so much for joining us again for yet another HIDA Prevention Summit and sharing your important approach to evaluating this Catalyst program, which is new. We're going to continue to evaluate it. And I think we're even going to lean into some health promoting relationship variables. We're going to start looking at those over the next year and building that data set too. Right now, we're going to enter into a 5-minute break, and we will see you all for our final presentation at 3:30 with Carlton Hall. You are not going to want to miss this. We're going to be talking about hope and what's love got to do with it. So we'll see you over there.
Thank you, everyone.